Sorry again. As I mentioned, there is a lot of technical difficulties today. So, right. So, in the previous session, we were discussing about. I hope I'm audible, right? So, please use the chat box, and as much as possible, please unmute yourselves and talk to me, or so that I know that you are interacting, you're listening. At least I am audible. Right. So, as I said in the previous session, we were discussing basis of communication, how we were required to. Thank you so much, Rundalis Desai. Thank you so much. So in the previous session, we were talking about the basics of communication, and today we'll be looking at the communicating back. So why is it necessary that we need to learn this? Why is it that included in our syllabus? This is basically used to enhance the therapeutic nature of the medical encounter. So most of the time, I think you might be remembering an example uh, that I have said in the previous session, that there was this girl who had cancer, right? And for her, she was not willing to take any treatment because her mother also had a previous had a history of cancer, and her aunt also had a history of cancer. And one had taken the treatment, and the prognosis was bad, and she kind of passed away. The other person was not willing for any treatment. See, the thing is that she had a lot of misconception. Even if I take this treatment, this is not going to benefit me in any way. So she had a lot of misconception. So in order to like remove the uncertainty, to enhance to reduce the uncertainty and remove the outcomes of the care, we need to learn how to communicate properly. So it also improves patient satisfaction to prevent inappropriate hope and guilt. So we shouldn't never ever give false hope to a patient. We shouldn't say that, okay, see, I know that you have so and so problems. I can maybe relieve you of your pain, or I can do something regarding this. See, we should never do that. So to prevent inappropriate hope and guilt, we need this. That is also one of the objectives, to prevent a conspiracy of silence. See, this is one area that you might have to take some time on. What is this? What is it? This called as conspiracy of silence. Has anybody heard of it? Conspiracy of silence. Conspiracy of silence is when everybody knows what is going around, but nobody is willing to come out and say that so and so is happening, right? That is, if there is a patient and if there is a caregiver, whoever it could be a spouse, okay? So there is this husband who is having CA lungs. He knows that his condition is deteriorating. He knows that for some, actually, he had a case like that. So I think he was 35-year-old male, and 35-year-old male, and he had CA lungs, right? So he knew that his condition is deteriorating. He knew that the prognosis is very bad, but he was not willing to say this to his wife. When we look at when we have a conversation with the wife also says that, see, I know that the condition is bad, but just don't let them know. Just don't let my husband know. See, both of them know what the outcome is. Both of them are aware of the prognosis, everything, but both are not willing to communicate this to one another. So that is called as conspiracy of silence. That is, everybody knows what is happening around, but nobody is willing to have a conversation, come out and say about this, and everybody kind of suffers alone. Here the wife is also suffering alone. The wife kind of cries, and she is alone in her suffering. The husband, when we look at the husband's condition, it is also similar. So both of them know their conditions, both of them are suffering, but alone. This is called a conspiracy of silence. And to prevent this conspiracy of silence, we might need to have communicate properly. We might need to have a conversation between the husband and the wife, so that they are together in this. It's not that they both can do like whatever. I mean, they can suffer alone. So conspiracy of silence means everybody knows what is happening, everybody has an idea of what is going around, but nobody is willing to come out and say this. So everybody is suffering alone, right? So that is called as conspiracy. This topic, this title, we might be looking into it again, right? So what is the impact of a proper communication? What is it that we get if we have a proper communication? If it is not proper, it can lead to a range of negative emotions like shock, disbelief, numbness, etc. For example, see, I'm working as a psychologist. So I'm working as a senior psychologist with Pallium. And suddenly, I get my biopsy report and I go to the doctor and say that, so this is my report. And he suddenly says that, okay, you have been diagnosed with cancer. You might have to take the treatment as soon as possible. Or maybe, see, you have already reached stage 4 of cancer and there is no other curative things possible. You might, the condition might be deteriorating and you might even, you can even die like within 3 months or something like that. See, this happens. There is a possibility that this can happen, right? So this information is going to bring this information is going to shatter me completely, right? See, I am going to be in shock. I might be feeling numb. I won't even feel anything. I might be in disbelief. And so these kind of factors get along if we don't have a proper communication. So how we need to communicate the news to the patient, how we need to communicate properly, and the way which we need to communicate is something that we need to look out. So if done well, it can lead to a stronger and trusting relationship that can help in better patient care. So if done properly, so there is a warmth in that relationship. Either it is between the doctor, even if it's between the doctor and the nurse, not doctor and the patient, or between the nurse and the patient, or between patient and relatives or the caregivers, whoever they are, right? So that is the impact of communication. So we'll just look upon one of the examples. Okay, I want whoever is listening, active, whoever is doing active listening to just give a moment to this. The patient is saying, "Doctor, I don't feel too good." Right. So immediately the doctor's response is, "You have not followed my instruction. I can see." See, immediately the doctor is dismissing the need, right? Here, what he is saying is that you have not followed my instruction. See, I have asked you to take medicine so and so. I have asked you to follow the diet. I have asked you to exercise a bit. See, you have not followed my instruction. That is why you're not feeling good. What happens if we communicate like that? See, here is a patient who has come to you, who is in a much vulnerable position, who has come to you with some need, right? And he is not in a very good position, right? He is feeling somewhat not good. There is some issue with him, right? There is some physical ailment, it could be emotional ailment, it could be anything. But somebody is approaching you and you are immediately dismissing him by saying that this is because you have not followed some instruction or something. This would come. See, the patient won't feel like talking to you anymore. The patient might say, okay, if I say something again, he is going to scold me. So, right. Maybe the doctor might scold me, so I won't say anything at all. So immediately the patient is going to stop. The patient might stop. Right. Thank you, Evelyn. The doctor need to listen to what the patient is saying. Exactly. Thank you so much. See, I can see that too. Tell me what is troubling you. Immediately, the doctor is acknowledging what the patient is going through, right? So here, the doctor is saying, see, I can see that too. I can see that you are in trouble. I can see that there is some issue with you. I can see that you are in distress. So tell me, what is it that is troubling you? So what is it that is troubling you? See, this opens the door for a lot of information that you might be able to receive. This is an open question. Again, we are not asking any leading questions as we have mentioned in the previous session. This is an open question and the patient will start describing what is it that really affecting him, right? So acknowledge whatever the patient is saying rather than dismissing. Another example, right? Doctor, I am unable to sleep at night. So immediately here, what the doctor is saying is that is because maybe you are sleeping during the day. Maybe that's why you're not able to sleep at night. Maybe you're sleeping during the day. See, we have a tendency to say this, right? Just forget about patient nurse, patient doctor and all. We have a tendency to say this to our friends also, right? See, that's maybe because you're sleeping during the day. That may be the reason that you're not able to sleep at night, right? You must be sleeping during the day, or immediate another response is that maybe, okay, take diazepam tabs, you should sleep well. Okay, immediately we'll be like referring or prescribing some medicines to sleep better. But here, what is it that we are lacking here? we are actually not looking to what the real cause is for the sleeplessness. What if it is something else? What if it's not? It's something that is causing stress to him. Taking diazepam tabs or not sleeping during the day is not going to help him in any way, right? So, reasons for sleepless nights may be more serious. It could be something more that we can imagine. So, how we should be replying is that, see, I understand. See, it must be very frustrating not being able to sleep, right? See, it must be very frustrating and it must be causing a lot of distress that you are not able to sleep at night. What has been troubling you, or what are you thinking when awake? Maybe the patient is. See, I have talked to a few patients who had sleep disturbance, and the major concerns would be like, see, who is going to look after my daughter after something happens to me? See, the child is just in school, is in 10th, and who is going to look after her? I'm worried that if at all something is going to happen to me, who is going to take care of her? So this thought, the patient might be like, might be stuck in this thought in like in a loop, and she won't be able to sleep. There might be some other concerns also. It could be pain. What if it is pain, right? So there might be a lot of reasons behind what the patient is telling to you. So it is very important that you explore those reasons. So Breaking Bad, as I said, it is usually called as communicating bad news. Is usually now used as communicating bad news. Any information which adversely and seriously affects an individual's view of his or her future. So whatever I'm going to say, this news is going to make a remarkable change. It is going to make a very it could be what do you say? It could be it's going to turn my world in a 360-degree. Okay, this is called as breaking bad news or communicating bad news. This information is going to change my life, like is going to change my life, or is going to take my life is going to take a 360-degree after knowing about this information, right? So it is going to seriously affect the individual's view of his or her future. So okay, I'm communicating that. So you have you had this fall, and this seems that your this many spine area has been deeply, or whatever it is, has been affected, and you may not be able to walk ever again. See, we are communicating this information, okay, for a person who was independent, who was a breadwinner of a family, who has like a lot of responsibility, telling to him that you will be forever be a wheelchair bound or bed bound is not easy. The information for him to comprehend is not easy, right? So this is actually going to take a big toll on the person's perception of his future. Okay, immediately the person might feel that, okay, I'm of no good. I'm not worthy enough. I won't be able to provide to my family. So these kind of thoughts will continue. So any information which adversely and seriously affect an individual's view of his or her future is called as BBN, or breaking bad news, or communicating bad news. Okay, right. So I would like all of you, I think I have 66 participants, to take a moment, look at this picture and say like what differences is between the first and the second egg. Okay, so that egg that's on the left side and the egg that's on the right side. You can use a chat box, or you can unmute yourself and just put your thoughts into it. What does the first picture show? Uh, can you please scroll down the chat box? It's a mess. Yes, it's a mess. First one is a very total mess. I completely agree. Thank you, Veronica. Thank you, Elvin. Everything is shattered. It's not done properly, right? Everything is complete mess. Thank you, Vaishnavi. Thank you, Purva. Thank you. Right. So we can see that in the first, see, we can break egg in both the ways, right? Either we can make a complete mess out of it, right? The yolk and the white, everything is kind of mixed, and the cracks are also kind of, it's a complete mess. But when we look at the second picture, we can see that it's properly broken down, and yeah, second one has already told the news, right? It's the news, the communication has been done in a very skillful way, right? The yolk, and we can clearly see the yolk, we can clearly see the protein, everything is completely done in a very skillful manner. So it's similar to how we communicate bad news. Either we can completely shatter, we can make a complete mess out of the situation, or we can do it in a very proper, skillful way, right? So breaking bad news is similar to breaking an egg. A certain amount of skill is needed, otherwise you are liable to make a mess. So this is not something that you can achieve in a day or two. This is going to take some practice and skill to do this. So we'll be saying how to go about it, and then a lot of practice might be needed from our side to learn how to do it properly, right? So this is for you, right? So you are the presentation was prepared for doctors, but it is fine, okay? So you are a GP or you are a nurse. Consider yourself as a GP or a nurse or a psychologist, whatever it is, whatever the profession is, okay? You have seen a patient about a week back for mouth ulcer, okay? So immediately you had given some medication, but we could see that the medicines has not, the patient has not, the body has not responded to the treatment. You advise him to go to a surgeon who then did a biopsy. Patient has come to you with biopsy report which reveals cancer. So how are you going to communicate? So the patient is sitting in front of you. Okay, imagine that the patient is sitting in front of you. Like this, we usually do if it's an off-site session, or on-site session, we would use this as a role play. Okay, we'll be like having actually two persons doing this thing. Right. So imagine yourself as this GP or the nurse who has seen the report, and how are you going to communicate? How are you going to communicate? Someone please, if possible, you can unmute yourself and speak, or you can use a chat box. See, there is a patient who is sitting in front of you with a biopsy report which reveals that the patient is having cancer, right? So how are you going to uh, communicate? We'll see a few responses that we usually listen, right? We will ask his present complaints. Okay, thank you. I can see that you have few people are typing, so I'll just wait for a minute or so here.
I would say that first to ask the patient whether he is okay to listen to it's going to be a very serious information I'm going to give you. Are you ready for it? Do you want anybody else to be with you at this time to support you, to get the environment ready for disclosing this serious information, and see what he knows, whether the previous doctor, the surgeon, has told him anything about this, that he's suspecting cancer. What does he think about it?
Thank you so much, Darshan. It's almost what we are going to explain, right? So there is a whole process made for the patient's response comfortable to make the patient comfortable. First, make the patient comfortable could be better if near one accompanies, right? So many. So thank you for the responses. Ask for depressing complaints. So as Darshan has said, what she mentioned is something called as warning shot. Okay, we'll be coming into that. So, but how we reach the warning shot stage is something that we need to look out to. We don't immediately start off with like that. So there is this whole process. Thank you so much, Deshan. It almost covered, but there is this whole process. Okay, right. Thank you so much. Thank you for the responses. Right. So what we usually see in the OP setting is that, see, your report says that you have cancer, you have to get admitted, and let's see if treatment is feasible. See, a patient who has come on his or her own way okay, a completely independent, is sitting in front of you, and he or she comes to know that she or she has cancer. This is, and you're like immediately just bombing them with this information, right? The patient is completely shattered here. The patient there has been a case where a patient has just ran away. We recently had a communication, recently had an experience sharing, and there a doctor was mentioning this. There has had experience where the patient would just run away, making screaming and all. We never know how this information is going to affect the patient. Okay, so we cannot just bombard them with the information. There has to be a way. Okay, there is another response. I'm sorry, you have been diagnosed with cancer. Perhaps it has already advanced, and I guess we don't have much treatment. I'm afraid you have only 3 months to live. Is this the way we're going to respond, right? The patient is going to be, even though the condition might be deteriorating, the patient might only have 3 months to live. But this is not the way the information has to be said. We need to say the facts as such in an honest way, but not in this manner, right? Here, the patient is going to completely, the whole world is going to come collapsing on him, right? So, we'll be coming on to the state, how the protocol, etc. But why is it that difficult? Why is it that communicating bad news becoming difficult? First one is environmental barriers. We may not have, say, considering a normal setting hospital, we may not have proper space. We might be walking around in a corner, and maybe the patient has just handed over you the report, and we will just go through the report and then we will be telling that, okay, you have been diagnosed with cancer. You don't have a proper space where you can have a conversation with the patient, where you can sit and have a conversation in private area, right? External interference, there might be phone calls in between, there might be emergency call from the ICU, there might be other things, there might be crowd, there might be noise, you might be walking around the corridor, and then you'll be like saying this. So these are the environmental barriers that we have when we are trying to communicate bad news. The medium, you might be using a lot of medical jargons or the language. There is a language barrier between them. Maybe the patient is not has a completely different language. So these are the environmental barriers. We may not have space. There might be privacy issues. There might be external interference like the phone calls, emergency calls, etc. And the medium, the language and the dialect. Why is it that difficult for the patients to ask for this? Why is it difficult from their side? Most of the time what they feel is that the doctor is too busy. See, I'm not the only patient whom the doctor has to see, right? There might be a lot of patient who is waiting outside the OP. So even if I feel like asking what my report says, or what the report, the further meaning of the report is, I won't feel like asking. Maybe he's like too busy. Maybe I should I should refrain myself from asking further. Most of the time the patient might fear the answer. What if the doctor says that I'm having cancer, or I'm having something else, some serious life limiting illness? What if he says that? The patients might have the fear to listen to the answer, right? Another reason, doctor is more interested in the physical care and do not want to know of their emotional problems. So they might be sitting in front of you with a lot of fear, anxiety, a lot of stress, but they won't say anything regarding their emotional side, because they feel that doctors are there to look out for their physical symptoms. Okay, here he is there, the doctor is present only to look at my physical symptoms, maybe my pain management, maybe he might do my pain management or something else, but he won't be willing to listen to my emotional issues. They feel that they might break down in front of the physicians. We have seen this usually, right? What if I cry down? What if I cry? What if I break down completely? What if I just throw a tantrum? What if I burst into my anger kind of comes out, right? They fear that they might let out their emotions, and they don't want to do this in front of everyone. This might again keep them from asking or further questioning the doctor. What if they demand more clarification? Doctors will stop treating them. So most of the time patients do have a lot of doubts and queries related to their disease condition. So what we see most of the time is that the patients feel, if I ask a lot, if I probe into my disease condition, if I ask a lot of questions, the doctor will feel like, okay, see, I am such a irritating patient, I won't, and I will just stop treating them. So these kind of apprehensions are there from the patient side, right? One is the patients feel that the doctor is too busy. They fear what we might be going to say. The patients feel that the doctors or nurses are more interested in the physical symptoms and they don't want to know about the emotional side. They fear that they might break down in front of the whole team or in the hospital setting, and they feel that if they demand more clarification, the team or the doctor or the nurse will stop treating them or may consider them as an irritating person, right? Right. So why is it difficult from professional side to communicate bad news? Why is it so? First and foremost thing is fear of getting blamed. You might have seen this in, especially in intense Indian scenario, like if something happens to the patient. Sorry, any queries or was it accidental? Right. So we have seen this, especially in an Indian scenario. If something happens to the patient, the whole relatives is going to come around and even maybe burn down the hospital, right? This usually happens in Indian context, right? So they fear, and they might put the whole blame onto the doctor who has been taking care of the patient. They will put this blame that, okay, you have been looking after the patient. You knew that this was going to happen. This is, you are responsible for the mother's or father's condition. Is, we have usually seen this in our hospital scenario, right? So doctors or professionals or nurses fear of getting blamed, letting the patient down. Also, we have this fear that, okay, why should I tell this and let the patient down? They feel depressed. Why should I convey this news? What if the patient asks difficult questions? What if the patient starts crying in front of me? What if the patient suddenly throws a tantrum, or suddenly gets angry or does something? This usually these fears are there within the professionals. And most of the time, the doctors or the nurses or the professional team, whoever is in charge of the patient, they feel like they want to protect the patient's feeling. How do I reveal a bad diagnosis to the patient? So you have a report which clearly says that the condition is deteriorating and the patient might pass away anytime soon. At the it's metastasis or the cancer has spread. The patient is in a very bad condition, but we feel like, I shouldn't be the one responsible to convey this bad news. How do I reveal a bad diagnosis to the patient? So a lot of doubts that way is also there, right? Next is feeling awkwardness, powerless, embarrassed. Again, this is for the whole team, right? See, there are at times when we have our own limitations, right? So there might be possible that, see, actually the condition is, see, we cannot take all the suffering away, right? We cannot take everyone's suffering away, or we cannot keep someone from dying, right? There are limitations. We need to understand that from our own, we need to do our best, we need to do our maximum, but we do have limitations. This has to be like clearly be understood by the team, whoever is looking after the patient, especially when it comes to medical healthcare system, right? So this powerlessness most of the time takes a big toll on the professionals. I feel completely powerless. I'm not able to help this patient out of this situation. These kind of feelings also cloud the professional's mind. The profession or the doctors or the nurses may not have enough time. This is another reason why it is difficult for the professionals. Being reminded of human vulnerability, so much pain, those kind of things. The family does not want me to reveal it. So most of the time, they assume that the family does not want me to reveal it to the patient. So these are the factors when it comes to the professional side, why it becomes difficult to communicate bad news. So we looked at some of the environmental barriers, we looked at some of the concerns from the patient side, why it is hindering the process of a proper communication, and then we looked at some of factors from the professional side which is hindering the process of a proper communication, right? So in order to do this, in order to avoid a proper communication, in order to avoid effective communication, what we do is we take up some distancing technique. in order to avoid this communication, we knowingly or unknowingly take up some distancing techniques. For example, see, I don't want to convey this news to the patient, okay, whoever is sitting in front of me. So I need to avoid this situation. So what am I going to do? I will have a very poor non-verbal communication. I won't have a poor contact. I will just avoid looking at the patient. I might just take a file nearby. I might take my phone and scroll. I might take a file nearby and just go through the file. I won't give eye contact to the patient. This is one way in which I'm avoiding the conversation. I might look busy. I might be always busy. I'll be like looking after the patient or doing something else. My facial expressions, again, I will show that I'm not interested in having a conversation. My tone of voice would be of very grumpy voice or a very not disgust, but at least I will be like very rude, so that I won't need to have this communication, right? Concentrating on physical tasks, maybe I'll check the pulse, I'll check all those things. I'll be more involved with the physical symptoms or some other physical task, maybe writing or checking or typing some physical task I'll be, so that I can avoid this conversation, right? Categorizing and labeling, mostly we'd say like, okay, she's a very difficult patient, it's very difficult to look after her or something like that, she is a she is a troublemaker or something like that. Never inquiring beyond physical symptoms. So what we do in order to avoid the emotional side, or okay, I cannot handle this emotional side, I won't be able to break this, I won't be able to handle the drama that is going to happen, the emotional surge that is going to happen. Okay, I'll just leave it there. I'll just focus on the physical symptoms. I'll just ask whether the patient has slept or whether the patient has pain or something like that. So I'll just inquire about the physical symptoms and avoid all the emotional or stressful factors that the patient is having. So, right. So we adopt certain distancing technique to avoid a proper communication. Right. So am I clear till now? Any queries, any doubts? Am I too fast? Should I slow down a bit? Any suggestions, anything like that? I hope the pace is fine. Should I slow down? Should I, anything? Thank you. Thank you so much. Thank you for the response, station. Thank you, Purva. Thank you. Right. This helps me, this non-verbal communication helps me, right? Thank you so much for all those who are responding, right? So why is it that important to break the bad news or communicate the bad news? To maintain trust, to maintain a proper relationship between the nurse and the patient, to maintain a proper relation between the doctor, to have a very good communication within the family members or the caregivers, right? To prevent inappropriate hope and guilt, to prevent hope. Most of the time they feel like, okay, if I take this treatment, I'm going to be devoid of cancer, or I will get completely cured of cancer or the pain. They might have a lot of confusion, uncertainty, a lot of doubts, a lot of hope they might be having. They might feel like, okay, maybe because I did this to my mother, that's why, because God is like punishing me now, that's why I have cancer today. So they have a lot of guilt, lot of uncertainty, lot of other ideas in their head. So which would be continue if we don't have a proper communication. To allow appropriate adjustment, so what needs to be done, what are the treatment plans, what other things has to be done from our end, so that they have a completely the quality of treatment is better. So in order to do this thing, we need to communicate properly to prevent a conspiracy of silence. Again, this conspiracy of silence is, when we talk about the topic, it is easy, but the person who is suffering alone, it might not be that easy for the person. The wife knows and she is crying alone, the husband knows that the condition is deteriorating and he is suffering alone. If they come together, it is much better, they will be in that suffering together, instead of being at two end and suffering alone, right? So to prevent conspiracy of silence also, we need to communicate bad news. So now we are moving on to how to communicate bad news, right? 6 steps to breaking bad news. I'll just talk about all these 6 steps in detail, and then I'll be coming to how the spike protocol comes into play, right? So First is getting started. Next is find out how much the patient knows. Third, find out how much the patient wants to know. Sharing the information, responsibility to the patient's feeling, and planning and follow through. So these are the stages in which we'll be communicating the bad news, right? Right. We'll be looking at into each points in detail, right? So first point is getting started. See, it's not that I can just go randomly and communicate bad news. I have to be prepared. I have to plan what I am going to say, what I am going to ask, so that I won't hurt my patient's feelings, right? So plan what you will say. Ask ask appropriate questions. Create a conducive environment. Create an environment where there is time, where there is space, where there is privacy, everything is there. Allow adequate time. See, communicating bad news is going to take an enormous time. It is going to take, see, you can do it in 10 minutes, you can do it in 2 minutes, but you can also do the same thing. It sometimes take an hour or 1.5 hours to break, because it is going to take some time. So make sure that you have adequate time before you communicate bad news. Determine whom to involve. Should I involve someone else? Should I involve the spouse? Should I involve the parents into this? We need to understand whom all we are going to involve while we are communicating the bad news, right? So getting started, in the first step, what we do is asking, plan. I'll plan what I'm going to say. I'll prepare what questions, appropriate questions. The environment, I'll have a check on the environment where we are going to have this communication. I'll make sure that I have adequate time, and I will determine whom to involve. Once the patient has come and we have a proper conducive environment, the patient is comfortably sitting, right? The next thing what we'll do is we need to have an insight of the patient, establish what the patient already knows, how it all started. It's an open question. So the patient is sitting in front of you, we'll ask an open-ended question, which is just how it all started, right? So that we know how much the patient already knows. So we'll be starting from that point, right? Assess ability to comprehend new bad news. Give them the option. See, I'll be saying like, okay, how did it all started? Okay, the patient would start like, I had this pain. I went to my local physician, and she gave me certain medicines, etc. Was there? Everything was given, but the medicines has not given any relief for me. So the patient will start elaborating the story, right? Just give time. Let the patient say. I'm not sure if in regular OPDs you have so much time, but this is the way it has to go about. Okay, I would like to talk about the same. I would like to talk about the same. Is it the right time now? Is it okay if I talk about the same right now? We are like letting the patient know that we are going to say something regarding the same. Right. Next, third step is how much the patient wants to know. See, we cannot trust, or we cannot just push the information into the patient, right? We need to get the patient's consent before saying anything, right? Recognize, support various patient preferences. So what if there has been cases where the patient shows that, okay, we'll have the patient sit next to me, and I'll make him comfortable. I make sure that I have adequate time. I will explore what he knows about his disease condition. The patient might be saying, okay, I have like shown this report to this person, and the doctor there said that this is so and so. So I'll just give a warning shot. Just like I think Dechen has mentioned, I'll say, whatever I'm going to say won't be much, is not something that is favorable in your state, favorable on your side. It's something bad that I'm going to say. It is called as warning shot. That is, you already mentioned that whatever you're going to say is something not favorable on their side, is something bad, is something that is going to affect them. We already mentioned that indirectly in our communication. This is called as warning shot. And then we'll ask, Okay, see, whatever I'm going to say won't be much on your side. It is something that might that is a bit serious or severe and all. And do you still want to know? We'll take the patient's consent. Do you still want to know? And at times, the patient says that I'm okay with this information, I don't want to know any further. If a patient is saying so, we'll stop then and there itself. We'll respect whatever the patient's decision is, right? If the patient is saying, see, I would like to move, then we'll have continue with the communication, right? So people handle information differently. We need to know that whether they are willing to know about it. Again, when it comes to Western context, we can directly communicate the bad news with the patients. Okay, but when it comes to Indian context, it is mandatory that we take the caregiver's consent also. We first might need to talk with the wife or the brother or the parents or the spouse, whoever it is. Okay, so we'll be having a conversation with the wife that okay, see, it is better that if we communicate this news to him, because there might be a lot of wishes or something, like a lot of unfinished business might be there from their part, so that it is better if you communicate that the condition is deteriorating. And if the caregiver says no, it is better, if he doesn't comes to know about any information, we'll again try to convince the caregivers. Okay, this happens only in Indian context. Okay, and if the caregivers are not willing, we may not be in a position to completely break the news to the patient. Okay, again, similar conditions arises, like if at all we break without the caregiver's consent, if we break or communicate bad news to the patient, and if the patient suddenly have anxiety attack, panic attack, or commit suicide, again the caregivers are going to blame the hospital or the institution or the doctors for the mishap that is happening, right? So in Indian context, we take the consent of the caregivers. And at times, there are cases where the caregiver does not want to reveal, but the patient wants to know. There are cases where these kind of scenarios happens, right? In this scenarios, we sit with the caregivers and say, see, the patient has been repeatedly asking for his prognosis and all. It is much necessary that we convey. Again, we have a conversation with the caregivers, and it is the patient's right to know about the information. We cannot withhold the information if the patient is demanding for the information, right? So this has to be kept on our mind. So a warning shot is given, and we'll ask, do you still want to know? Do you want to know further? Do you want other information also? And if the patient or the caregiver, the patient is willing for that, is giving your consent, we move along with the information, right? Next is sharing the information. So what we do here is that whatever information is actual facts, we will be communicating exactly the same thing, but in a much kinder way, right? It's not done in a very rude way, but whatever the facts we need to communicate, even if we know that the condition is deteriorating, it's like very less days, the condition is deteriorating, and something might happen anytime. This information has to be communicated, but in a very slow, in a way that in between the patient might start crying. You might need to give time for the patients to express his or her emotions, right? Say it, then stop. You need to give adequate pauses in between the informations. Check what the patient has understood. It is possible to explore concerns while giving information. Pay attention to emotions. Give space for the patient to express the emotions. Painful concerns may remain invisible. They need to be probed. There might be other fear factors that the patient might be having. You need to probe those also. Be clear, be gentle, and very slow. This has to be done in a very slow and gentle manner. You cannot just rush into the information, right? Don't minimize the severity. We tend to minimize the severity. We tend to say that, okay, it's just a small mass that is there. It's just a small thing that is there. We tend to minimize the severity. Never ever minimize the severity, right? So whatever are the actual facts, you might need to communicate just the same, but in a very clear, gentle, slow manner, in which giving space for the patients to express their emotions. Responding to feelings, affective responses, for example, they might cry, they might scream, they might show tantrums, they might be angry towards you. Whatever are the affective emotional responses that they are showing, you might need to sit and respond, or you might need to give space for them to express. Cognitive responses, they might be having a lot of queries, they might be having a lot of doubts, other basic things might be there. You might have to respond to that also. Basic psychophysiological response. The palpitations might increase, they might start sweating, there might be a lot of emotional and psychological responses that are going to come. You might need to address those. Give time to react. Make sure that there is time for the patient to process the information, express the emotions, right? Listen. A lot of non-verbal communication might be needed at this point. Planning and follow. So after all the communication has been done, plan for the next steps. Discuss the potential sources of support. Give contact information, right? So we'll just come along once again. Getting started. Plan what you are going to say, what questions you are going to ask. Second thing is just have an insight into what the patient already knows. Okay, what do you know what the report says? Did the doctor there say something about this? What is that you're having? Just ask how it all started. Explore how much the patient wants to know. Give a warning shot that whatever you're going to say is not in their favor. Do you still want to know? Get their consent. Get their consent on how much the patient wants to know about his or her condition, right? So do that, give warning shot and take their consent. Do you still want to know? See, what I'm going to say is not a very good thing. Do you still want to know? Share the information, whatever you're saying, the knowledge passing should be factual, correct, honest things. Never give false hope. Do not minimize. Be gentle, be clear, be very slow. Respond to their feelings. They might have a lot of emotional response. Plan and follow, right? So this is called as the spikes protocol. It's a mnemonic that we usually use. Setting up is arranging the place, having a proper place to have the communication. Perception is knowing how much the patient knows about his condition, getting insight into the patient's condition. Invitation, we invite the patient. Do you still want to know? We take consent, we give a warning shot, we take consent. That is called as invitation. We invite the patient into giving the information, right? Knowledge is where we actually share the information. Emotions, we give time for the patient to respond. We give time and space for the patient to express his or her emotions. Strategy and summary is where we look out for the plan. What is the next plan of action, right? This is called as the Spikes protocol, and Spikes protocol is one thing that we usually use to communicate bad news, right? Any doubt in this slide? Setting up perception, knowing what the patient knows about his condition. Invitation, we invite the patient. Do you still want to know? Do you want to know about your disease condition? Knowledge, we share the information. Emotion, we give space for them to express. Strategy and summary. So this is called as the Spikes protocol, right? So we'll move on to the next topic, that is collusion. Shall we? Are we all on the same page? Thank you. Right. Collusion is when we know that an information is withheld as an act of love, right? For example, we know that the prognosis is bad, or know that the condition, the diagnosis is cancer or something like that, but we withhold the information. We withhold this information from knowing, from telling this to the patient or relatives, or it can happen in any level, as mostly done as an act of love. Why should we just tell him that he is having this? Why should we know that? Why should we tell him that the condition is deteriorating? Most of the time we keep this information from telling them. Information about diagnosis, recurrence, prognosis in the advanced terminal stage of disease, and medical details about the deceased person withheld from the significant persons. Okay, So whoever is having an issue, whoever is withholding the information about diagnosis, withholding information prognosis from the significant person is known as collusion. If the information uh, is withheld, it is called as collusion positive and collusion negative. Collusion positive is when the patient is not aware of the prognosis or the diagnosis. Okay, that is the information is withheld. Collusion is positive, right? So collusion can happen between the professionals and the relatives. Most of the doctors, physicians, or the nurses feel that okay, I won't tell this information to them. If I tell them, they're going to break down. It is going to hurt them. So I'll just withhold this information. It can happen between the physicians as well. It can happen between the physicians and the relatives. It can happen between relatives and patients. The patient won't say the information to the relatives won't communicate properly to the patient, might withhold the information from the patient. It can happen between relatives and relatives. Most of the time there is this so much stigma around diseases, right? I won't just like I don't want the my native area to come to know about this disease condition, so I'll just withhold the information, right? So I might withhold the information between relatives, the in between the relatives also. This can happen, right? Okay, so I'll just give an example of a proper example that we had in our IP where this collusion was positive. Okay. So we had a patient. She was 23 years old. She was admitted here with osteosarcoma. Okay. She had osteosarcoma in pelvis. She had osteosarcoma in pelvis and hemipelvectomy. I think she had on the right side, and hemipelvectomy was done for her. Okay, and she was given this information that it is cured, it is not going to recur or anything like that. Suddenly, after a few days, she had a terrible pain on the right side. Okay, and she was admitted at our IP for the pain management. Everything was done. Morphine was given. I think yeah, all the medication part was taken care of. And in the first admission, she used to sit. Okay, she used to sit in a wheelchair. She used to sit in the hospital bed with tilting the bed and all. She used to do a lot of craft work. She was absolutely brilliant and all. Okay, she was very creative also. So she used to do all these craft paper flowers and all, and used to gift us all. Right. In the second admission, the pain was so severe that she was not able to sit. So we sent the patient for a review at Regional Cancer Center, Trivandrum, and they came back. From the Regional Cancer Center, it was told to their parents, both the mother and the father, that the cancer has spread to the left leg and the condition is very deteriorating. This information was withheld from her. The patient started getting pain on the left side also. Suddenly, she had terrible pain in the left side. She kept on inquiring, I don't know why, but my left side is also hurting now. And, even the slight movements in my hip area is causing a lot of pain. I'm not able to do crafts works like I used to do. She used to say this. And as the condition deteriorated, there was a lot of anger, which was directed towards the mother. The mother and the daughter had a lot of conflict. She started throwing tantrums. She felt like, mother was not looking after her. A lot of issue was there. So we had multiple sessions with the mother and father to break this collusion, to break the collusion, to break the bad news to the daughter. They were not willing in the first few sessions. Okay, we needed to have, like, I think we had like 5 sessions with the mother and father alone to get their consent. Finally they gave consent, and they said that they won't be the one who will be like breaking the bad news. The team has to say. So our physician and I was also there. We kind of sat with the patient. We took the entire session, was, I think it was 1 hour, 1.5 hour session it was. Towards the end of the session, she cried a lot. The information was communicated. She did not talk to the parents, to the mother, for 3 days. So, yeah, right. So, anger is one thing that is always there. As I mentioned in the previous case, the patient, it's we know for a fact that if something is wrong with our body, we will be the first person to know, right? So this child knew that something wrong was happening, but era people around her just kept on giving false hope. See, I'm going to have aggression. See, I'm going to throw tantrums. See, this is my emotional response. So this is going to happen. A lot of guilt, right? So these are the effects of having collusion. Both parties grieving but alone. See here, she is grieving, the parent is also grieving, but both of them are grieving alone. When collusion is like we break the collusion, they come together in this. They come together for the in the suffering. Constant stress and burden or hiding the truth. See, once we keep the information from the other person, we have this in our mind. Okay, I'm not saying the truth. Whatever I'm saying is giving a false hope. I'm hiding this burden. This stress is also going to hamper inability to eat, sleep, and communicate with others. Patients feel out of control and trapped. This is a case. This is for you people. Amrita, 65-year-old female, has been diagnosed with cancer, CEO ovary. Sanjay is her son, and he has come to meet you, right? So Sanjay has come to meet one of our nurses, right? He appears very confused and restless. He does not want to reveal the diagnosis to his mother. How are you going to handle Sanjay? So, what is the first step that you are going to do? Any one of you? Sanjay's mother, she is 65-year-old. She is having CEO ovary, but he is withholding the information from her. How are we going to handle Sanjay? Just one or two responses we do. Maintain good. Okay. So he is saying that it's there is no need to convey the information. How are we going to make Sanjay understand the importance? Very good. Thank you. Thank you, Purva. So we need to have sessions with Sanjay to communicate why it is important, how this might be able to affect him. Listen to him, understand from his point of view. Very good. Understand why he is afraid to tell the news, why he is withholding the information. Is he having any other second thoughts? What is it that is troubling them? We need to have an idea of that also, and then we might need to convey it to him. Even after conveying, even have after having sessions with Sanjay, if he's not willing, maybe we may not be able to go further. Okay, we might need to stop there. That is also there. We cannot push the information, we cannot just make it mandatory. Managing collusion, acknowledge that there is collusion, explore reasons like Dechen has mentioned. We need to explore why they are withholding the information, right? With the relatives' consent, elicit worries and questions regarding illness, feedback to the relatives regarding the awareness of the illness and readiness, explain to the relative the importance of reassurance and honesty, encourage dialogue between the patient and the relative. Make sure that they are on the same page, they come together, and we prevent conspiracy of silence. Remember, value statements by family member. We should always value. If they are completely denying, then we might have to take a step back. We cannot force them to do this. We cannot force information to the patient or the caregivers or between them also. Acknowledge family members' emotions. Listen to family members. Understand who the patient is as a person as well as who takes the decision in the family. Elicit questions from the family members. After having all this, did I listen? These are the areas where we need to self-reflect upon. Did I explore their beliefs, what they believe in? Did I respect their values, their decisions? Did I make an acceptable working diagnosis? Did I share options for investigation or treatment? Did I share in decision making? Was I a good part in it? Did I make some attempt to my patient understand? From my part, did I do my best? Did I develop a good relationship? So these are some self-reflective thoughts that we need to best learn through experience. So breaking bad news is something, it's a skill as breaking an egg. So we need to practice as much possible, identify our skills and try to refine them, identify our shortcomings and try to overcome them. Sometimes there are physicians, there are nurses who won't be able to do communicate bad news. It might emotionally affect us. We need to check upon that. If we are not in a position to do it, maybe we need to hand over that to someone who is able to do it. There are no fixed guidelines. Should be patient-centered and context and culture-oriented. As I said, it is completely different in each context, each culture. It is different. We need to focus that. We need to respect that also. Accept limits. There are limitations. We have our own limitations. We have our own what do you say? We might. There are points where we might get stuck. So never set back. That shouldn't be setting you back. No role model. Never assume. Never ever assume. Any doubts? Any queries? We come to the end of the slide. Thank you so much. I would like to know if there are any queries or any doubts or anything.
Thank you, Rajika, for the wonderful session. Anybody have any doubts?
If not, thank you so much, Sonam. Just let me know if at all there is any doubts that are coming up. Please, you can ask in the WhatsApp group, or you can reach out to the faculty. Okay, thank you so much. We have one case presentation, I presume, right? Shall we move on?
Yeah.
Rachel.
Can I share my screen? Is that possible at all?
If you want, you can.
Yes, please. I think I need permission for that. It says host disabled participant screen sharing.
We are trying from our end. Just a second.
Thank you. If it's not possible, it's fine, I think.
Have made you the co-host. Is it okay right now? Are you able to share now?
When I press share, oh yeah, there it is on the right side. I know if it's visible, my screen.
No, Dachen. Screen has not come.
I'm sorry. I think I will do it from the center.
Okay. Okay. So shall we share?
Yes, please. I've made some changes.
Dachen, just let me know when you have to let the team know when you have to change the slides. Okay.
Okay.
Right.
Thank you. Please start now.
Right. Yes.
Yeah. So,
Can you able to see the slide?
yes, it is visible. So my name is Etchen, and I would like to thank TIPS and Pallium India for giving me this opportunity to do a small presentation today, and especially for this whole course of the training that we have been able to learn throughout. And the presentation that I'm going to bring about today is a lovely patient, an elderly gentleman whom I had taken care of last year. I'm sorry I don't have a patient I'm taking care of present, because at the moment I'm at home. I'm not working for the past few months. So this patient is, next slide please, is 85 years old male who's traveled all over the world, came with diagnosis of decompensated chronic liver disease with advanced hepatocellular carcinoma. So this was when I worked in St. James University Hospital in Leeds, UK. And he had been fit and fine all throughout his life. And this was the first time he's been, this was not his first admission though, but he had been diagnosed earlier, but this was his, the only disease that he had. Next slide, please. The present complaints were he had this huge ascites, abdominal distension, which was accompanied by pain. He was quite weak and fatigued. He was lethargic. He had loss of appetite. He was drowsy most of the time. And he had itching all over his body, especially on his arms. Next slide, please. Going to the history, as I mentioned earlier, he was diagnosed a few months prior to this admission. He had been in and out of hospital because of this diagnosis, but during this admission, he had the present complaints that I mentioned earlier. Even though he had decompensated chronic liver disease, it was good. He did not have any breathing difficulty. He did not have melena or did not have any GI bleed. Next slide, please. So I'm going to go very quickly because I think I have only 5 minutes for the presentation. So examination, his vital signs were almost stable. General examination, he was mild pale. His hemoglobin was a bit low. I don't know exactly how much it is because this presentation I'm doing in retrospect. I don't have the patient file with me. He was mildly utric because of his increased bile levels. He had pedal edema as well. And systemic examination, he's seen in his CNS, he was drowsy but arousable. And when he was aroused, he was completely oriented time, place, and person. His cardiovascular system and respiratory system was completely normal. Abdomen, he had ascites that I mentioned earlier. It was quite, abdomen was very distended. In fact, they were causing a lot of discomfort. He had pain, which went to 5 to 8. Next slide, please. Next slide, please. I'll go to treatment a bit later. Psychosocial aspects I did not mention about this. He is unmarried. He's never married in his life. Alone. And even though he was living alone, he had no support at all at the age of 85, no children, no wife. So, and he was not able to carry out his activities of daily living, which is a big concern. Just one person, that was his sister with her husband. And even though he had his diagnosis, he always remained optimistic about life. And he always was looking forward to going back home. He wanted to do shopping for himself, always looking forward to that. And he was reported by his sister as becoming very forgetful lately. And then she also mentioned that he has had some accidents in the past wherein he had kept the tap open and then the water had leaked into his house. And in the UK, it's usually carpeted. So the whole house had been got wet and they had to change the whole carpet. You know, there's a lot of work involved. So she was getting very concerned whether he would really be able to cope up at home. That was one of the concern from the family side. Next slide. I'm not going to go in detail. It was managed by paracetamol, codeine, and morphine. Pantoprazole was given for him. He had severe nausea as well, as not mentioned, for which he was given pantoprazole and ondansetron. And he had constipation, which was attributed to his his pain medications. He was getting Laxitol, which is a laxative, and he was getting ursodeoxycholic acid for his bile, to thin his bile, bilirubin level, and he was getting spironolactone for his ascites, and for his itching, he was getting chlorpheniramine, and he was getting nutrition supplements because he was very, very emaciated. By the end of 1 month, it was quite bad. He has lost 4 kgs a week. I'm sorry about the pantoprazole dose. It's split. There's a mistake there. It's 40 milligrams, not 4 milligrams. Next slide, please. So the main concern, because today's class of communication, I wanted to stress was that even though my patient, he had advanced stage of the disease, he was always optimistic. He was thinking that he's going to go home, he's going to go shopping, and he had not talked about his future, what he wanted with his family. In fact, his sister was saying that she was concerned about how she's going to manage after he passes away, how she's going to manage his affairs, because he had not given the power of attorney to anybody. So his funeral and all that has to be arranged. And secondly he was very drowsy with inability to participate in ABS. And because of his drowsiness, most of the time during meals time, he's very drowsy because he's not able to eat. So we had to work it out how we are best able to meet his nutritional needs. So before that, I would like to go on the first advanced stage of the disease. When I asked him about what his plan, when he said, I want to go back home, I want to do shopping, I realized that he has not really understood how severe, what is the prognosis. So I spoke to his treating doctor and I said, would you like to speak to him again? Because he does know he has got cancer, but he does not know how severe it is. It is an advanced stage. So the doctor did speak to him again, and following which I spoke to him. And then I developed my communication further from there. And then from there, we went on to do a little more about it, which I'll go later. And then I referred him to the palliative care team, who was also able to give us more support. So the palliative team comes every day except on weekends. So they come and counsel him and give him small shots to understand how severe it is, making plans for him. And then I referred him to the nutrition team, who were able to give him some nutritional supplements for him. And then occupational therapy, because abroad what they do is we refer patients to occupational therapy, who would assess the patient and see how much support he needs. So depending on what occupational therapy reports, the patient is eligible to get that support. So I've referred to that. So he was seen by the nutrition team, he was seen by the palliative team, and he was seen by the occupational team. And third, I think I've written everything there, except for decision on place of care. So that was one of the major things that I mentioned. Next slide, please. Can I go to treatment, please? So treatment, I'm going to really go rushing because I don't want people to leave halfway. So treatment was medications, as I mentioned earlier, for his pain, which was very, very important. Because of his pain and discomfort, he was not able to participate in his activities of daily living. And as I mentioned earlier, he loved traveling. He loved to be independent. Even when he was drowsy, we tried to help him. He says, no, I want to do it myself. He wants to walk to the toilet. Sometimes he tells me, don't hold me. I want to do it myself. So very, very independent person. So we had to take care of his pain and the side effects of the pain medications. And then he had his acidic tap to tap the fluid from his abdomen with replacement of human albumin solution regularly. Then he had his regular counseling on the part of the palliative team, the doctors, and from our side. And I always involved his sister when we were doing the counseling. And what we did now, another thing what we did was at this stage when he was aware about his disease condition, when he was, we did not push actually, because most of the time he was drowsy. So when his sister came in during visiting time, he would be drowsy. So we would wait for the next day. Sometimes we miss, being together and discussing. So times when he was away, we did discuss. We have something called advanced care plan, wherein we discuss about what is important to him, what matters most to him. And in our hospital, we have a booklet like this. I don't know whether my video is, whether I'm visible because I can't see myself. So in this, it's got everything inside as to, what advanced care plan is. Advanced care plan is what is a, if I had to define it, I would. So I have to define it. Advanced care planning is a process that supports others at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. This is at a time when they are not able to speak for themselves. So at this time when my patient is able to speak for himself, this advanced care planning is his voice. This booklet will be his voice to say what he wants. Even now, even not just for later, but even now what he wants. So the first few questions are about what it's all about personal preferences. For example, the first page will be about, about a patient, his name and so on. And second one will be about what are your hobbies, what are your activities that you like to continue to enjoy, and what makes you feel calm, what makes you anxious, what is your faith. And I mean, every detail of the patient is mentioned here. And then where would you be content to be cared for if you're no longer able to stay where you currently live? This is usually in the abroad setup. In an Indian setup, we usually live with a family, but slowly, even in our society, we are disintegrating, and many elderly people are living alone even today. So where would you be content to be cared for when you are dying? The first choice, second choice, and so on. And then even later on, it's about the medical care. Would you like to be resuscitated? Or would you like to stop medical treatment at certain time? All these details. This is a completely a different topic. Advanced care planning is completely a different topic. Not go in detail. So we did fill this form, and this was a huge blessing for the family because they sorted out a lot of issues through this advanced care planning. And after that, it was decided that he will go to hospice. And then the hospice, we were going back and forth communicating. They said they did not have a bed at the moment. And finally, we had to take him to a nursing home with the patient's consent. Finally, he agreed and we had to send him to a nursing home. And from nursing home, when the bed becomes available in the hospice, when it deteriorates, they were willing to take him. So we got this sorted out through a good communication. And that was through this actually, because this booklet had everything in detail. Next slide, please. So in summary, I think I don't want to go in summary because I think it's going to take time. Next slide, please. So discussion points, what would be a priority care for this patient? Mainly, as I mentioned, it would be pain, and then talking to him about what his main concerns were. Points to be considered while breaking bad news. I think we had gone through today's class about the 6 steps. That's very, very important. And from my experience, I remember when I just graduated from my nursing, I was given a slip by a doctor through a patient. A patient, young man, came to me when I was working in a school. And he had written saying that this patient has HIV. Can you explain it to him? I had no training in palliative. I didn't know how to disclose it. I was myself shocked because I know this person. And the way I disclosed it, I'm not very proud of it now when I look back. And there was another incident when another teacher told me that he was sharing his incident when a doctor during his rounds, his wife had just delivered a newborn baby. Just few days, and in the ICU. And so during the rounds, the doctor just mentioned saying, I'm sorry, your daughter is having a developmental disorder. And he was shocked. He didn't know how to take it. And he told me, I feel very bad because you know how I reacted. I held the doctor by his shirt. And he started shouting at the doctor, how dare you say that about my daughter? She is beautiful. She cannot be disabled and things like that. And then the next day, slowly, when he came back to his, senses, he thought, I did something that's really bad. I did something bad to the doctor. He's a big consultant, a very senior person. So the next day during rounds, in front of all the other doctors, he apologized. So I think one of the mistake was it was disclosed in a way that was not very fruitful, actually. So when I look at my experiences, I think through this training, I've learned a lot. And especially when you said today about sleeping issues that patients may have. When somebody says, I'm not able to sleep at night, what do we say? Oh, you're sleeping during the day. And we just close the matter. Many a times we are very, very judgmental. And I think as nurses or whatever profession we are, this training will really help us to help our patients who are going through a difficult time already themselves, that we'll be able to, heal their wounds and their families. So I think is there anything else I've written here, discussion points? How important is place of care, especially during the last days of life? I would like to die in my home. I don't want to die in the ICU with ventilators.
So, thank you so much, Dejan. That was a very comprehensive and very elaborate. I highly appreciate the effort that has been put into this. But as you have mentioned regarding the pediatrics, especially when it comes to pediatrics, disclosing or communicating bad news is very sensitive, very, very, very sensitive, I would say, when compared to the adult cases. That is something that we need to even maybe be more aware of how we need to, the skills that we need might be like we need to polish even after having all the skills, we might need to polish that, because pediatrics is an area communicating bad news. It's not easy. It takes an enormous effort and time. We need that, or else they are going to the reaction is going to be very worse, So and regarding the I think the place, I think how important is a place of care. I would, if at all the patient is in a position to respond, I would leave to the patient his or her wish, I would say. I think you have already mentioned that whatever care plan was given to this patient was very patient centered, I would say, and that is how it should be. Any more points to add, Shimana?
I think so. Decision making. Is if the patient is able to respond, definitely we have to respect the patient wish. So we have to understand their wish. So they are the first person to make decision. If they are not able to take the decision, like unconscious or semi-conscious condition, then the primary caregiver will take the decision. So definitely we have to make them understand that what is the condition of the patient. So what are the, if they take a wrong decision, definitely sometimes the patients may be going through a lot, maybe suffering. So that we need to prevent it. So we have to make them understand. The caregivers needs to understand about the patient condition and prognosis. So then they will take a good decision.
Because there has been cases when the patient's condition is like very deteriorating, the caregivers might push for further treatments, which in effect takes the patient to much more pain and other difficulties. So we might need to have a session with the caregivers, telling if at all the patient is not in a position to give consent or say about his wish, his or her wish, then we might have to convince, tell clearly to the caregiver the condition, what are the plans, what are the treatment plans, what can be done if treatment or curative treatment is possible. If not possible, so then what can be done? Maybe we cannot just let like maybe we can just suggest or we can just give options. Again, the decision has to come from the caregiver.
Sometimes, yeah, we have patient like sometimes at the end of the life care situation, that patient says like, I want to die at home. So some that time the caregivers were not willing to take the patient to home because the end of life care the symptoms, they were not able to manage the end of life care symptoms, that kind of thing. So that time what we do is we call a family meeting and tell them that this is very very important, your loved one wants to die at home, so we will help you. So I will, yeah, facilitate that process, and we have our we have syringe driver, we load the medications and train the caregiver how to operate the syringe drivers, and we put a subcutaneous line and send them home. So after one day, usually we heard like he died at home peacefully. So we need to this kind of the primary thing is make
The patients
yeah.
We had a patient who had requested for palliative sedation because of pain. We had one patient who herself requested for palliative sedation. Then there was this patient who requested for a prayer to be conducted in our IP setting. So we arranged a room where the patient could have a prayer. The church people, the priest came here and we took a prayer, and also it is always the patient. The patient is our first and foremost priority. But if at all the patient is not in a position to say, again, the next caregiver, whoever is the primary caregiver, we'll be like taking their suggestions. We might be saying, giving our options, the decision will come from that. Was that clear enough? Did we clarify?
Yes, I wanted to share what Dr. Rajagopal was sharing one on the YouTube. I remember he said about how much of percentage of poverty has been attributed to medical treatment that are not necessary, causing distress to patients. And I think planning ahead would solve major of its problems. Like if suppose I have got cancer, I would have advanced care plan and say that this is what I want and this is what I do not want. So when something happens to me, when I cannot speak, my family know this is what she wanted. And they will not have any arguments within themselves. They will not have guilt. They'll have peace within themselves, and I will get what I wanted. So I don't know whether advanced care planning, I wanted to ask this question, whether advanced care planning is practiced in India.
Yes, that is very, very necessary. We need to do it. If there is a condition like end of life care situation, if the patient is able to take a decision, definitely you have to tell the patient is about this advanced care plan, and they can give a letter like, so I don't want to build the artificial life support, that kind of thing. So they can. So then we have a proof, no? So we can attach the cases, and whenever so these kind of things we can. Definitely, when the patient comes to palliative care, definitely we have to tell the patient and make them understand that what is palliative care, what are what things we used to do in palliative care. Mainly, we are focusing on the symptom management. We will be trying to control their symptoms through and make them comfortable as much as we can. So we can able to give a peaceful death, right? So these you have to make them understand, and then if they're willing to write the advanced care plan, definitely you can.
So do we have any, because TIPS is the center, isn't it, WHO Collaborative Center in India for palliative care. Would like to know whether there is any format that we follow for advanced care planning already made so that it'll be easy for everybody to follow and you do not miss a point.
Yeah, we have one. I think I need to talk to the concerned persons and share it with you.
Thank you very much.
Thank you, Rachan. Thank you so much. I think we are ahead of our time. Sorry for taking. Yes.
One important thing. Can we go back to the medication? I know the time is goes up. So here, this patient is on tab codeine and syrup morphine, right?
Yes.
So tab codeine comes under weak opioid.
Yes, that's TID, and PRN morphine.
Yeah, syrup morphine is 10 milligram PRN. So why you are compiling both?
So we give this codeine regularly, but in between, if he has a breakthrough pain, so they wanted to give morphine for that.
So for the breakthrough pain, you used to give a syrup morphine 10 milligram, right? As you rescue doctor.
Only just everything oral.
Okay.
And then the palliative nurses, when he was discharged, they give this list of anticipatory medications, midazolam, everything written, as just in case he needs later.
Okay, fine. Thank you. Bye.
Thank you so much. Thank you for sorry for taking so much time, and sorry for the commotion that confusion that we had in the beginning. Thank you all. Please, if at all there is any queries, please put up in the WhatsApp group. Thank you.